Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular session, I'll be discussing the very important topic in the cardiology, that is the ischemic heart diseases. So one of the common presentations to the emergency department from the cardiology point of view is the ischemic heart diseases. So these patients, they present with the chest pain. That will be the common presentation. And few patients with massive anterior wall MI, they can present with acute left ventricular failure as well. And some of the patients, they present with giddiness, that is secondary to bradycardia. That is usually in case of the inferior wall MI. Okay, so this will be the varied presentations, but among all these, the chest pain is the most common symptom. And these patients with ischemic heart diseases, if you see, like what is the most common cause for this ischemic heart diseases? That is the atherosclerosis. So atherosclerosis of the coronary arteries, that is the most common cause of the ischemic heart diseases. So in this session, I'll be discussing what are the risk factors for the development of the atherosclerosis and what will be the presentation in patients with the ischemic heart diseases and how do you treat these patients with ischemic heart diseases. So all that I'll be discussing in this particular session. Okay, right. So if you see the ischemic heart diseases, why does it occur? So it occurs mainly due to supply and as well as demand mismatch. So ischemic heart diseases, it is the condition where there is inadequate supply of blood and inadequate supply of oxygen to a portion of the myocardium. And when the blood and as well as oxygen is not supplied to the myocardium, the synthesis of ATP does not occur within the myocardium, right? And in these patients with ischemic heart diseases, there is a typical imbalance between the myocardial oxygen supply and as well as the demand. So if you take any particular muscle in our body which is continuously working 24/7, that will be the cardiac muscle. So cardiac muscle should be having the continuous blood supply and as well as the continuous oxygen supply. So always 24/7, the cardiac muscle is under the demand of the oxygen and as well as the blood. So if there is an imbalance between the myocardial oxygen supply and as well as demand, that will make the individual to develop what is called as the ischemic heart diseases. And as I have said you, what will be the most common cause of myocardial ischemia? That is the atherosclerotic disease. That is the most common cause of your ischemic heart disease. So atherosclerotic disease of the epicardial coronary arteries. Now, what are all your epicardial coronary arteries? That includes the branches of left main coronary artery, that is left anterior descending artery, and as well as the left circumflex artery, and then the right coronary artery and as well as its branches. So in this epicardial coronary arteries, you have the development of the atherosclerosis. And this particular atherosclerosis will cause reduced blood supply to a part of the myocardium. So thereby what will happen? So there is regional reduction in the myocardial blood flow. So once there is regional reduction in the myocardial blood flow, there is inadequate perfusion of the myocardium supplied by the involved coronary artery. So that is what will happen in patients with the ischemic heart diseases. So if you take up the detailed pathophysiology in patients with the ischemic heart disease, so the central core of the pathophysiology is that this myocardial ischemia, whichever is developing in patients with ischemic heart disease, it is the concept of the myocardial supply and as well as the demand. Okay, so the supply is less, the demand is more. That will contribute to the development of the ischemic heart diseases. Now you take in the normal conditions, whenever there is the myocardial oxygen demand, right? In the normal conditions, whenever there is a demand for oxygen, right, this myocardium will control the supply of the oxygen rich blood. Okay, myocardium will control the supply of, right, the supply of the oxygen rich blood, mainly to prevent, right, mainly to prevent the underperfusion of the myocytes and subsequent development of the ischemia and the infarction. So it is right. So in a normal patients, or in a normal individual, the myocardium will control the oxygen demand, and thereby the oxygen which reaches the myocardium will supply to the myocytes, and thereby there will be prevention of ischemia and as well as the infarction. But what happens in atherosclerosis? What happens in patients with ischemic heart diseases? So if you take the major determinants of the myocardial oxygen demand, so what is that we are discussing? The demand is more, the supply is less. Now, what are these major determinants of the myocardial oxygen demand? The major determinants are the heart rate. Okay, so this myocardial oxygen demand, we use it as MVO2. That is called myocardial oxygen demand. So the major determinants are, number one, the heart rate. So more is the heart rate, right? More is the heart rate, more will be the demand. Okay. Next, myocardial contractility. So increase in the myocardial contractility, more will be the demand. And next is the myocardial wall tension, which is nothing but the stress. So these three are the important determinants of the myocardial oxygen demand, right? Now, if an adequate supply of oxygen to the myocardium requires the satisfactory level of the oxygen carrying capacity. Okay, so if the cardiac myocytes have to receive the adequate amount of oxygen, there should be satisfactory level of the oxygen carrying capacity of the blood. Now, this oxygen carrying capacity of the blood, right, the oxygen carrying capacity of the blood, it is determined by, right, it is determined by the inspired level of the oxygen, right? It is determined by the inspired level of the oxygen, and it is determined by the pulmonary function, and it is determined by the hemoglobin concentration and as well as the function. Okay, so the satisfactory level of the oxygen carrying capacity, it completely depends upon the inspired level of the oxygen, pulmonary function of the individual, hemoglobin concentration and as well as function. Okay, now this adequate level of the coronary blood flow, if it is there along with the following functional capacities, then the myocardium will be able to reach its demand. Okay, so satisfactory level of the oxygen carrying capacity is not only sufficient, there should be also adequate level of the coronary blood flow as well. Okay, and blood flow through this particular coronary arteries, how does it occur? The blood flow through the coronary arteries, it occurs in a phasic fashion. And if you take all over the body, it receives the blood supply during the systole, but the heart, it receives the blood supply during the diastole. Okay, and about 75% of the total coronary resistance, see, the blood is flowing through the coronary arteries, but there is resistance within the coronary arteries. Now, at which level you have the resistance? So, about 75% of the total coronary resistance to the flow occurs across three sets of the arteries. Now, what are these three sets of arteries? Number one, large epicardial arteries, that is considered as the resistance level 1. At the level of prearteriolar vessels, that is considered as the resistance level 2. And at arteriolar and intramyocardial capillary vessels, that will be resistance level 3. So 75% of the total coronary resistance to the flow occurs across these three sets of the arteries. Now, out of which will give maximum resistance, which will give the trivial resistance. So if you take the large epicardial arteries, that will give a trivial resistance, right? That will give a minimal resistance to the flow of blood. I'm talking about the resistance in the absence of the atherosclerosis. In the absence of atherosclerosis, this large epicardial arteries will give a minimal resistance, whereas the major determinant of the coronary resistance, so if you take the major resistance, right, the major determinant of the coronary resistance is found at resistant level 2, that is prearteriolar vessels, and as well as at R3, that will be arteriolar and intramyocardial capillary vessels. Okay, and normally this intramyocardial, right, normally this intramyocardial resistance vessels, they demonstrate a great capacity of the vasodilatation. Right, they demonstrate a great capacity for vasodilatation. Okay, which one? That means what I mean to tell you, whenever there is a demand during the exercise, which vessels will undergo vasodilatation and thereby meeting that particular demand, that will be your R2 and as well as R3. That is mainly the intramyocardial capillary vessels, they demonstrate the capacity for vasodilatation. Right, now for example, the changing oxygen needs of the heart with exercise and emotional stress, they affect the vascular resistance. In this manner, they regulate the supply of oxygen and as well as the substrate to the myocardium. So what I mean to tell you at this point is, at the level of your R2 and R3, there is maximum resistance. And at the same time, the R2 and R3 are the one which will undergo maximal vasodilatation whenever there is a demand. Okay, so the changing oxygen needs of the heart with exercise and emotional stress affect the coronary vascular resistance. In this manner, they regulate the oxygen and as well as the substrate supply to the myocardium. Okay, so you have the three levels. So out of these three, you see here the upper one. So what is this upper one telling you about? That is, the location and size of the arteries supplying the blood to the heart is shown at the top. Okay, so what all we have? We have macro circulation and micro circulation. Macro circulation, it includes the epicardial arteries. Then micro circulation includes small arteries, arterioles, and as well as the capillaries. The epicardial arteries, if you see, like they are more than 400 micrometers. And the small arteries, if you see, right, they are of dimension less than 400 micrometer, arterioles less than 400 micrometer, and capillaries less than 10 microns. Okay, so these are the divisions. And if you take the second, vasomotion of the arterial segments occur in response to the stimuli. So the main stimuli for the vasomotion, so depending upon the requirement like exercise or stress, that will decide the flow of blood across the coronaries. And last one, the main function of each of these arterial segment is shown next, followed by deception of the relative resistance to the antegrade flow. So this is what is telling you about the transport, regulation, and at this level of the capillaries, you have the exchange. Okay, so these capillaries and as well as the arterioles, right, these are the intramyocardial vessels that will undergo maximal vasodilatation during the stress and as well as during the exercise. Now, this is what is normal, what we have discussed now. So now let me tell you what are all the various causes, right? What are all the various causes of reduced coronary blood flow, and thereby there is demand and supply mismatch. Okay, first important reason is atherosclerosis. That is the most common cause. Okay, so by reducing the lumen of the coronary arteries, the atherosclerosis, it limits the appropriate increase in the perfusion. Right, they limit the appropriate increase in the perfusion. So thereby what will happen? The demand is more and the supply is less. Okay, and when the luminal reduction is severe enough by atherosclerosis, myocardial perfusion in the basal state is reduced. Okay, so because of this, what is happening to the myocardial perfusion? The myocardial perfusion is getting reduced. So one of the reasons for reduced blood supply to the coronaries is atherosclerosis. Next, the other important etiology is the Prinzmetal angina. So coronary blood flow also can be limited by the spasm, right? So in Prinzmetal angina, which is also called vasospastic angina, there will be spasm of the coronary arteries. And the other reason for reduction of the coronary blood flow will be the arterial thrombi and rarely the coronary emboli. Okay, as well as even the ostial narrowing, right? Even the ostial narrowing due to aortitis right, due to aortitis, even that also will contribute to reduced coronary blood flow, right? Then we have some congenital abnormalities which will contribute to reduced coronary blood flow. Now, what are these congenital abnormalities? They include the origin of, right, they include the origin of left anterior descending artery from the pulmonary artery, right? The origin of the left anterior descending artery from the pulmonary artery. Left anterior descending artery, it has to originate from left main coronary artery, which is a branch of ascending aorta. But if it is originating from the pulmonary artery, that will cause the myocardial ischemia. And even there can be development of infarction in the infancy itself. Okay. So, because the pulmonary artery contains the deoxygenated blood. So, the deoxygenated blood will be going to your myocardium causing myocardial ischemia and myocardial infarction in the infancy itself. So, that is about the congenital anomaly, right? The another important condition where there will be reduced coronary blood flow is when the myocardial ischemia can also occur if myocardial oxygen demand is markedly increased, and particularly when the coronary blood flow may be limited, as occurs in severe left ventricular hypertrophy. See, in certain scenarios, the myocardial oxygen demand increases. What are those scenarios? Like you take in patients with left ventricular hypertrophy. The cause of left ventricular hypertrophy could be anything. Either it could be due to hypertension or it could be due to the aortic stenosis. So, any condition where there is increased myocardial oxygen demand and there is no adequate flow accordingly, that is also the reason why there can be myocardial ischemia, right? Next, the another reason is reduction in the oxygen carrying capacity is also the reason why there is reduced oxygen flow to the coronaries, right? Now, what are those conditions where there is reduced oxygen carrying capacity of the blood? That will occur in patients with severe anemia, and that will also occur in the presence of carboxyhemoglobin. So, severe anemia and presence of the carboxyhemoglobin. These are the two things which will reduce the oxygen carrying capacity, and that will cause the myocardial ischemia, right? Next, now apart from that, there are two or more causes of the ischemia which can coexist. What are the coexisting conditions where there can be development of the myocardial ischemia, right? The coexisting risk factors include hypertension, and at the same time, the patient may also be having the atherosclerosis as well. Okay. So, hypertension and coronary atherosclerosis, if there is coexisting, or if there is atherosclerosis, along with that, there is also presence of anemia. Even this also will contribute to the reduced coronary blood flow and then resulting in the ischemia. And we have a form of angina called as the microvascular angina. What do you mean by the word microvascular angina? So, microvascular angina means where there is abnormal constriction or there is failure of, right, there is failure of the normal dilatation. Okay, so abnormal constriction or failure of normal dilatation of the coronary resistance vessels, even they also contribute to the development of the ischemia, right? And because of this, there is development of angina, and this form of angina is called microvascular angina. So, these are all the causes of reduced coronary blood flow or the conditions where there is increased demand and reduced supply. So, to summarize, most common cause will be atherosclerosis. Next, prince metal angina, arterial emboli, rarely coronary emboli, or even aortitis of the branching vessels in case of the inflammatory pathologies. Congenital abnormalities like the origin of left anterior descending artery from the pulmonary artery, the myocardial ischemia secondary to myocardial oxygen demand, that is increase in myocardial oxygen demand like left ventricular hypertrophy secondary to aortic stenosis or hypertension. Then reduction in oxygen carrying capacity that happens in anemia and carboxyhemoglobin. Two or more causes of ischemia if it coexists, like atherosclerosis and hypertension, atherosclerosis and anemia, and then microvascular angina. So these are all the conditions where there can be reduced coronary blood flow and as well as demand and supply mismatch causing the development of ischemic heart disease. Now, out of which, let me discuss about the atherosclerosis. So if you take this, the most common cause of the ischemic heart disease being atherosclerosis, you need to know the coronary atherosclerosis which occurs in the epicardial coronary arteries. It has some major risk factors, right? Now, what are the major risk factors for the development of the atherosclerosis? That includes increased levels of the LDL, that is dyslipidemia. Number 2, cigarette smoking. Next, hypertension, and then diabetes mellitus. So these are the major risk factors which will contribute to the development of the atherosclerosis. Now, this atherosclerosis, what it does, it will disturb the normal functioning of the vascular endothelium, right? Now, once the normal functioning of the vascular endothelium is disturbed, what will happen? First of all, let me tell you, like, what is the normal functioning of the vascular endothelium? So, if you take the normal functioning of the vascular endothelium, it includes number 1, controlling of the vascular tone. That is one function of the vascular endothelium. Number 2, maintenance of antithrombotic surface. That is second important function of the vascular endothelium. And third important function is the control of the inflammatory cell adhesion and as well as the diapedesis. Okay, so these are the 3 important functions of the vascular endothelium. Now, once there is endothelial damage, this particular function is being disturbed. Okay, so once there is the endothelial cell dysfunction, there will be loss of these defenses, right? There will be loss of these defenses. Now, once there is loss of these defenses, there will be inappropriate constriction causing reduced coronary blood flow, right? And second important is there is loss of, it will maintain the antithrombotic surface, which one? The vascular endothelium. So now once the endothelium is damaged, the luminal thrombus formation occurs. Okay, luminal thrombus formation occurs. And third important is abnormal interaction between the blood cells will be there once there is loss of vascular endothelial function. Now, what will be that abnormal interaction between the blood cells? That includes abnormal interaction of the monocytes and the platelets, right? And the platelets, okay? And the another important problem because of the loss of defense mechanism is activated vascular endothelium. So the loss of vascular endothelial defense, that will lead to all of these abnormalities. Okay. Now, once these particular abnormalities develop, what will happen in the blood vessel? So all these 3 functions are being maintained by the vascular endothelium. Atherosclerosis development is disturbing the vascular endothelial function, and these are the events that will happen because of the loss of defense mechanisms, and thereby what will be the effect in the blood vessel. So the functional changes in the vascular milieu ultimately results in subintimal collection of the fat, subintimal collection of the smooth muscle cells. There will be accumulation of, right? There will be accumulation of the fibroblasts, and there will be also accumulation of the intercellular matrix. Now, all these are present within the atherosclerotic plaque. Okay, so all these, they contribute to the formation of the atherosclerotic plaque. Now you have to understand the two important points. The combination of the vulnerable vessel. What is that vulnerable vessel? That is atherosclerotic vessel. The combination of a vulnerable vessel in a patient with vulnerable blood. What is that vulnerable blood? Having anemia, having carboxyhemoglobin. These two will promote the state of, right? These two will promote the state of hypercoagulability and hypofibrinolysis. Okay, so vulnerable vessel and vulnerable blood, that will promote the state of hypercoagulability and as well as the hypofibrinolysis. And this vulnerable plaque and vulnerable blood, this is especially true in patients with diabetes mellitus. And this particular atherosclerosis, whichever is developing, it does not usually occurs in a diffuse manner in a continuous fashion. This atherosclerosis, it develops at irregular rates. It occurs at irregular rates in different segments of the epicardial coronary arteries. Right? In different segments of epicardial coronary tree. Right? And these different segments of atherosclerotic plaques which are happening in the epicardial coronary artery, that will lead to segmental reduction in the cross-section area, and that is what is nothing but the plaque formation. Okay, so basically the atherosclerosis is not happening in a diffuse manner in the blood vessel. It happens in the segmental fashion within the epicardial coronary tree, right? And thereby the cross-section area will be reduced, and that is what is being done by your plaque formation. Okay, now if you see the predilection for atherosclerotic plaque, you have to understand that in a blood vessel, which particular site has the highest predilection for atherosclerotic plaque. That includes the site where there is increased turbulence in the coronary flow. Now, where is that increased turbulence in the coronary flow? Such as the branch points. Branch points in the, so like for example, the left main coronary artery is dividing into left anterior descending artery and as well as the left circumflex artery. Left anterior descending artery, it is originating from left main coronary artery. So it's a branch point. So that is the site where there is high turbulence and where there is high chance of atherosclerosis, right? Then you take left anterior descending artery, the branches that we have is the septal branches. So septal branch which is coming from the left anterior descending artery, it's a branch point where there is increased turbulence and there is that particular point is the increased risk of the atherosclerosis. Okay, next. Now, whenever there is decrease in the luminal size because of atherosclerosis, what will be the effect? See, the effect completely depends upon how much of the epicardial coronary artery is being stenosed. Okay, so if stenosis reduces the epicardial coronary artery by 50%, you have a set of manifestations, and if it reduces by 80%, you have a set of manifestations. Now, let us just discuss like what happens if the epicardial coronary artery it is reduced by 50%, right? So when a stenosis reduces the diameter of, right, when the stenosis reduces the diameter of the epicardial coronary artery by 50%, there is limitation of ability to increase the flow, right? There is limitation of ability to increase the flow, right? And thereby increased myocardial oxygen demand cannot be met. Okay, so that is like when the 50% of the coronary artery is being reduced, whereas if 80% of the coronary artery lumen is reduced, when the diameter is reduced by 80%, the blood flow at rest may be reduced. Okay, so at rest the blood flow is reduced, and any further decrease in the stenotic orifice, right, any minor decrease in the stenotic orifice that can reduce the coronary blood flow dramatically, right? That will reduce the coronary blood flow dramatically. And once this reduction in the coronary blood flow occurs dramatically, that will cause the myocardial ischemia, right? That will cause the myocardial ischemia at rest, or that will cause the myocardial ischemia even with minimal stress, right? Even with minimal stress. Okay. So when the reduction is 50%, there is just only limitation of the ability to increase the flow to meet the increased myocardial oxygen demand. Just there is only limitation, right? But when 80% it is reduced, the myocardial oxygen demand cannot be met, and even further minor decrease of more than 80% if it occurs, there will be dramatic myocardial ischemia at rest or with minimal stress. Okay. Now, this particular atherosclerotic plaque, whichever is there within the vessel, if it ruptures, what happens? See, the acute coronary event occurs whenever this atherosclerotic plaque ruptures. So, upon the plaque rupture and upon exposure of the plaque contents, two important and interrelated processes are set into motion. What are those two important and interrelated processes? That includes, number one, the platelets are activated and aggravated, right? The platelets are activated and aggregated. The second important is the coagulation cascade is activated, leading to the deposition of the fibrin strands. These are the two things. Now, this particular thrombus, right? This particular thrombus, which is composed of the platelets and as well as the fibrin, right? Thrombus, which is composed of the platelets and as well as the fibrin strands, they trap, right? They trap the red blood cells, and thereby they will reduce the coronary blood flow, right? Thereby they will reduce the coronary blood flow, and that will lead to the myocardial ischemia, right? That will lead to the myocardial ischemia. So that is about what happens whenever the plaque is being ruptured, right? Next, the another important point is the location of the obstruction influences the quantity of the myocardium which is being rendered ischemic. Okay. So now, if the location of this atherosclerosis, or if this location of the obstruction, if it is at the left main coronary artery, what happens now? The entire left anterior descending artery and left circumflex artery is not getting the blood supply. So if the atherosclerotic plaque is present at left main coronary artery, or if it is present at proximal left anterior descending artery, that is considered to be highly dangerous, right? That is considered to be highly hazardous or the dangerous. Okay, that is very, very important. So location of the obstruction also influences the clinical manifestation within the individual, right? The another point is, whenever there is chronic severe coronary narrowing, and when there is development of myocardial ischemia because of chronic severe coronary narrowing, that is usually accompanied by, right, usually associated with the development of the collateral vessels. So now let us just assume this is the area where there is the narrowing because of the atherosclerosis, and if this particular narrowing develops gradually, right, and if the ischemia develops gradually, there will be development of the collaterals around that obstructed area. That the collaterals will develop only when there is chronic severe narrowing, right? And this particular development of collateral vessels especially occurs whenever the narrowing occurs gradually, right? And the well-developed collaterals, right? Well-developed collaterals that will maintain the viability of the myocardium at rest, right? The well-developed collaterals will maintain the viability of the myocardium at rest, but during exertion, right? But during exertion or during increased demand, right? During exertion or during increased demand, remember, this collaterals cannot maintain the viability, right? The collaterals cannot maintain the viability. Okay, so this is about the atherosclerosis, which is the most common risk factor for the development of the ischemic heart diseases. Now, because of atherosclerosis, what is happening? There is reduced blood supply. Now, what will be the changes that happens in the myocardium, right? What is the effect of the ischemia? So, during the episodes of inadequate perfusion caused by coronary atherosclerosis, what happens is the myocardial tissue oxygen tension, it drops down, right? During the episodes of inadequate perfusion caused by coronary atherosclerosis, the myocardial oxygen tension falls down, and that will cause the transient disturbances of mechanical, transient disturbances of biochemical, and transient disturbances of the electrical function of the myocardium. That is what is the effect of the ischemia. That is what is the effect of the ischemia. And remember, the coronary atherosclerosis, it is the segmental and it is a focal process that usually causes non-uniform ischemia, right? That usually causes the non-uniform ischemia. Now, let us first discuss about the mechanical abnormality. So, during ischemia, during ischemia, there will be disturbance of the ventricular contractility. What will be the disturbance of ventricular contractility? There is development of segmental hypokinesia because of reduced blood supply and development of ischemia. There can be even development of akinesia. There is no movement within the wall. And in severe cases, there can be bulging, that is dyskinesia can occur. Okay. So, all these severe hypokinesia, akinesia or dyskinesia, all of them, they will reduce the myocardial pump function. Right? They will reduce the myocardial pump function. Right? Now, let me just show you the sequence of events that will happen because of the myocardial ischemia. The sequence are, number one, there is endothelial and microvascular dysfunction, right? And because of which, what will happen? There is loss of defense mechanism of the endothelial cells. Next, there is decreased subendocardial perfusion. Next, at this point, there will be abnormal metabolism within the myocardium, and that will cause abnormal ST segment changes. Either ST segment depression if it is ischemia, ST segment elevation if there is infarction, right? And there will be microinfarction or myocardial fibrosis. And once there is development of myocardial fibrosis, that will continue to develop the diastolic dysfunction. And once there is diastolic dysfunction, there is decreased segmental perfusion further, because once there is diastolic dysfunction, the myocardium is receiving the blood supply during the diastole. So further there is decrease in the myocardial blood supply, resulting in decreased segmental perfusion, and thereby there is regional wall motion abnormality. Once there is regional wall motion abnormality, that will contribute to the development of the systolic dysfunction of the myocardium. So initially there is a diastolic dysfunction because of the fibrosis development, and later there is systolic dysfunction in these patients with the atherosclerosis. Now, the problem is that if the development of ischemia, if it is gradual, right? If the atherosclerosis is developing gradual, then there is development of collaterals. So the viability of the myocardium is maintained, that is well and good. But if there is abrupt development of severe ischemia, then what will happen is, see, abrupt development of severe ischemia, where all it can happen? It can occur as a result of total or subtotal coronary occlusion that can happen because of the atherosclerotic plaque rupture, right? And that is associated with failure of the normal muscle relaxation. So at this point, there is development of the diastolic dysfunction, right? And then subsequently, what will happen? There will be also diminished contraction. So that will lead to the systolic failure or the systolic dysfunction. So the abrupt development of severe ischemia can occur as a part of total or subtotal coronary occlusion, and that is associated with impairment of normal muscle relaxation, and subsequently there will be diminished contraction, right? And you need to understand that ischemia of large portions of the ventricles, if it occurs, that will cause the transient left ventricular failure. Right? That will cause transient left ventricular failure. Whenever there is ischemia to large portions of the ventricle, if it occurs. And if there is ischemia in the papillary muscle apparatus, then that will contribute to the development of the mitral regurgitation. Okay. So the point is, the outcome of the individual depends upon how much area of the myocardium has been ischemic or infarcted, or is there any ischemia of even the papillary muscles also or not. So if the ischemia is transient, remember, it can be associated with development of stable angina or the angina pectoris. Whereas if this particular ischemia is prolonged, it can lead to the myocardial necrosis. Right? It can lead to myocardial necrosis and as well as scarring of the myocardium. Right? So that is what will happen depending upon the duration of the ischemia. Now, what will be wide range of abnormalities whenever there is myocardial ischemia, necrosis and infarction? The wide range of abnormalities will be in the cell metabolism, in the functioning of the myocardium, and as well as the structure of the myocardium. Okay, so there will be, these are all the mechanical disturbances, right? These are all the mechanical disturbances that can occur during ischemia. So I said you have mechanical abnormality, you will have electrical abnormality, you will have biochemical abnormality. So mechanical abnormality we are done. Now you take the biochemical abnormality. So you take the normal myocardium. Normal myocardium, it metabolizes the fatty acids and as well as glucose. And this particular glucose, it is metabolized to carbon dioxide and water. So because of the metabolism of the fatty acids and glucose, there is synthesis of the high energy phosphate, that is ATP. But whenever there is severe oxygen deprivation, the fatty acids, they cannot be oxidized. So the myocardium is completely dependent on the glucose. And this particular glucose, in the absence of oxygen, it will undergo anaerobic metabolism, and that will result in the synthesis of the lactic acid. And whenever there is synthesis of the lactic acid, remember, the intracellular pH is reduced. Okay, the intracellular pH is reduced. So once the intracellular pH is reduced, the synthesis of the high energy phosphate like ATP and synthesis of the creatinine phosphate, that will be reduced, right? That will be reduced. So this will be the biochemical abnormality. Then what will be the electrical abnormality? See, whenever there is ischemia or infarction, there is impaired cell membrane function. That will cause the leakage of potassium and making the cell into a state of repolarization. And there will be uptake of sodium by the myocytes, causing depolarization. And there will be also increase in the cytosolic calcium. So basically, what is the abnormality within the cell caused by the ischemia? Either there can be impairment of repolarization or the depolarization. So the next important is the severity of the damage it is determined by the duration of occlusion as well. Okay, so the severity and duration of the imbalance between the myocardial oxygen supply and as well as demand, it will determine whether the damage is reversible or the permanent. So when do you think that it is reversible? If the occlusion, if it is for less than or equal to 20 minutes in the absence of collaterals, then the ischemia, whatever it develops, it is reversible. Whereas when do you consider that myocardial ischemia or myocardial necrosis is permanent? When the occlusion, if it is more than 20 minutes, then there will be subsequent myocardial necrosis that will happen, right? So there is mechanical event, right? That is hypokinesia, akinesia and dyskinesia. Then the electrical events, right, where there is movement of the potassium out, leaky potassium channel, entry of the sodium or entry of the calcium, right? And you also have some electrical events like arrhythmias, which I'll discuss. So now whenever there is an ischemia, what does the ECG show? The ischemia also causes the characteristic changes in the ECG, such as there will be repolarization abnormality. Why? Because of leaky potassium channels. And that repolarization abnormality is evidenced by the inversion of the T wave. And if that particular repolarization abnormality is very severe, then that can also cause the displacement of the ST segment. And not only that, this particular ischemia also causes few more changes in the ECG. That includes transient T wave inversion. When will there be transient T wave inversion? If there is transient T wave inversion, it probably reflects non-transmural, right? Non-transmural intramyocardial ischemia, right? Intramyocardial ischemia. So that is what is the presence of transient T wave inversion represent, right? Then transient ST segment depression, it often reflects the presence of patchy subendocardial ischemia and the presence of the ST segment elevation in the ECG, that is thought to be caused by, right? That is thought to be caused by more severe transmural ischemia, right? More severe transmural ischemia. Okay. So the ECGs like transient T wave inversion, transient ST segment depression and ST segment elevation, what do they represent is what is given here, right? Then I said you that electrical instability is there because of that leaky channels. So that electrical instability, it is manifested as the premature ventricular contractures, right? And this premature ventricular contractures, they can progress, right? They can progress to ventricular tachycardia and as well as the ventricular fibrillation. And most of these patients, they die due to the ischemic heart disease, mainly because of this ventricular tachyarrhythmias. Okay, so this ischemia will induce VT or VF, and that can make the individual to develop a sudden cardiac death. Okay, so this is about the effects of ischemia, right? So mechanical changes, right? Biochemical changes, and then the electrical changes. What will be the biochemical changes? The biochemical changes are during severe form of hypoxemia, right? The myocardium is not able to utilize the fatty acid. The energy source is completely from the glucose. Thereby there is formation of lactic acid. There is acidemia. That will be the biochemical change. And these are the electrical changes that will happen within the myocardium. Now, followed by the atherosclerosis and the effects of ischemia. Now let me discuss in detail about the stable angina pectoris. So if you see the classification of the coronary artery disease, we classify that into the one individual developing ischemia and then the infarction, right? And this ischemia, depending upon the severity, we classify that into the individual developing stable angina, then Prinzmetal angina, then unstable angina. USA is unstable angina. And if you take this infarction, depending upon the ECG changes, you have ST elevation MI and non-ST elevation MI, right? So this is the spectrum of the coronary artery disease. Out of this unstable angina, ST elevation MI and NSTEMI, these three together constitute the acute coronary syndrome, right? Now, let me discuss about the stable angina pectoris in detail. So, this particular stable angina pectoris, it results from transient myocardial ischemia, right? The blood supply to the myocardium is reduced for less than 20 minutes, right? Reduced for less than 20 minutes. And for the development of stable angina pectoris, remember, the greater proportion is seen in males rather than females. And greater proportion is also seen in elderly individuals more than 60 years. But if you take in males, the risk increases at the age of more than 50 years itself. But whereas in females, the risk increases at the age of more than 60 years of age, right? And what will be the important clinical manifestation in stable angina pectoris? That will be in the form of the chest discomfort. And how is this particular chest discomfort described as? It is being described as the heaviness of the chest. It has been described as the pressure over the chest. It has been described as squeezing over the chest. It has been described as smothering or choking over the chest. So this is what is the description of the chest discomfort, right? And some individuals, they have this particular sign called as the Levine sign. So what is this Levine sign? If the patient is asked to localize the pain sensation, what he or she does is, they will place the hand over the sternum, or sometimes they place the clenched fist over the precordium, where exactly is the localization of the pain. So the placement of, right, the placement of the clenched fist over the precordium, right, the placement of clenched fist over the precordium while describing the chest discomfort, that is what is called as the Levine sign. And if you take the character of this particular angina, it is crescendo, decrescendo pattern. So as the time progresses, the pain increases, right? And once the individual takes rest, or once the individual takes sublingual nitrate, the pain decreases. So angina is usually crescendo, decrescendo in nature, right? And the pain, it is typically more severe at its onset and gradually progresses, right? And what will be the duration of the pain? It will be there for nearly around 2 to 5 minutes. And this particular pain, it will be radiating pain. And where it radiates, so it radiates to both the shoulders and it radiates to both the arms, okay? It can radiate to either one shoulder or it can radiate to both the shoulders as well. It can radiate usually to the left arm, but it can radiate even to both the arms as well. So usually it radiates to ulnar aspect of the left arm. That will be the most common site for radiation. And what is the reason for radiation? Because of same dermatomal pattern, right? And if you take few more points of the chest pain of stable angina pectoris. It is a radiating pain that can even radiate to the back, interscapular region, root of the neck, jaw, teeth, and as well as the epigastrium. These are all the various areas where the pain can get radiated. Then rarely the pain is localized below the umbilicus also. That usually happen in case of the inferior wall MI or the right ventricular MI. And the pain can also radiate above to the mandible as well, right? And occasionally the angina is localized below the umbilicus also, right? Even below the umbilicus also. That is what you will see in case of right ventricular MI or inferior wall MI, right? Then this myocardial ischemic discomfort does not radiate to the trapezius muscle. If the pain of the chest discomfort, if it is radiating to the trapezius muscle, it is more typical of pericarditis, right? It is more typical of the pericarditis, right? And sometimes in females, there can be sharp, fleeting chest pain, which is of dull in character, localized in the left submammary area. Okay, that is occasionally due to myocardial ischemia. Now, if you see the episodes of the chronic stable angina, these episodes, they are caused by, number one, exertion. What is that exertion? Exercise, hurrying, sexual activity. So upon exertion, the pain will increase. And the pain will also increase with emotion like anger, stress, fright, frustration. These are the emotional disturbances which will increase the anginal pain. And this particular anginal pain, it is relieved by taking rest, right? It is relieved by taking rest. Okay. And we have a terminology called the angina decubitus. So angina decubitus is that where angina may occur at rest, right? Where the angina may occur at rest while the patient is in the recumbent position, right? While the patient is in recumbent position, the angina can occur at rest in case of stable angina pectoris, and that is what is called as the angina decubitus, right? And these patients with angina pectoris, you know, they may be awakened at night by typical chest discomfort and as well as dyspnea. So they will have this nocturnal angina. Now the point is, what is the mechanism for the development of the nocturnal angina? Nocturnal angina may be due to episodic tachycardia, right? Nocturnal angina may be due to diminished oxygenation as the respiratory pattern changes during sleep. And third reason is there is expansion of the intrathoracic volume. Why there is expansion of the intrathoracic volume? Because in recumbent position, the venous return increases. So once the venous return increases, what will happen? That will increase the cardiac size. Okay. Once there is increase in the cardiac size, remember, there will be development of the wall tension where the patient with ischemic heart disease cannot bear this. Okay. Once there is wall tension, there will be increase in the myocardial oxygen demand, but there is a atherosclerosis. Demand is more, supply is less. So that will lead to, right, that will lead to the ischemia and as well as transient left ventricular failure. Right, transient left ventricular failure. Okay, so that is the mechanism for the development of nocturnal angina. These are all the reasons, right? Next, the another point is this stable angina, it is also precipitated by some unfamiliar circumstances, like it gets precipitated by heavy meal. It can get precipitated upon exposure to cold environment or even combination of these can also precipitate the development of the angina in case of stable angina pectoris. And this particular exertional angina, typically it is relieved within 1 to 5 minutes. How? By taking rest, right? So by slowing or ceasing the activities rapidly by rest. Or this particular exertional angina is also relieved by sublingual nitroglycerin as well, right? It is also relieved by even sublingual nitroglycerin as well. Now, if you take the severity of the angina, it is conventionally summarized by Canadian Cardiac Society of Functional Classification, and the patient's functional capacity, it is being described by the NYHA in stable angina. Now, let me discuss both of them. So, let me discuss the Canadian Cardiac Society Functional Classification as well as the NYHA classification. See, this is a table directly from the Harrison. So, we classify this into 4 classes. Class 1, 2, 3 and 4. So, in case of the NYHA classification, if you take class 1, these patients, they have a cardiac disease, but without resulting limitation of the physical activity. So, ordinary physical activity, that does not cause fatigue, that does not cause palpitation, that does not cause dyspnea, that does not cause even the anginal pain. That is class 1. Whereas class 2, they have the cardiac disease, but there is slight limitation of the physical activity, right? That means these patients, they are comfortable at rest, but when they do any ordinary physical activity, then there will be development of dyspnea, palpitation, fatigue and as well as angina upon doing ordinary physical activity. Whereas you take class 3, where there is marked limitation of the physical activity, right? These patients also, they are comfortable at rest, but whenever they do less than ordinary activity, right? Whenever they do less than ordinary physical activity, then there is development of angina, there is development of palpitations, there is development of dyspnea and as well as fatigue, right? Then you take class 4. Class 4 is that these patients, they have inability to carry on any physical activity without discomfort. That means even at rest also they will have angina. Even at rest also they will have fatigue, dyspnea and palpitations. Okay, so that is according to your NYHA. Now you take the Canadian Cardiovascular Society Functional Classification. So what this tells is, ordinary physical activity such as walking and climbing states does not cause the angina. Then when will be the development of angina then? According to class 1, according to Canadian Society, angina presents with strenuous or rapid or prolonged exertion at work or recreation. That means your Canadian classification, it is telling you only about angina, not about dyspnea, palpitations or fatigue, right? Then class 2 Canadian classification, there is slight limitation of the ordinary physical activity. So that is walking or climbing states rapidly, walking uphill, walking or stair climbing after meals in the cold or when under emotional stress or only during the few hours after awakening, the individual will have angina. So the individual is having slight limitation of the ordinary physical activity, right? So even you see here, walking more than 2 blocks on the level and climbing more than 1 flight of stairs at normal pace can also contribute to the development of angina, right? Whereas you take class 3, where there is marked limitation of the physical activity, walking 1 or 2 blocks on the level, even that can also cause the development of angina. Okay, whereas class 4 is that inability to carry out any physical activity without discomfort, anginal syndrome may be present even at rest. So what is the difference between your Canadian classification and NYHA classification now? NYHA classification, it tells you about dyspnea, palpitations, angina, fatigue. But Canadian classification, it tells you only about the angina, depending upon the physical activity, right? Depending upon the physical activity. Now, we have a terminology called as the angina equivalents. See, in certain group of individuals, you don't feel the angina, you don't feel the chest pain. Apart from chest pain, you will have the other manifestations of the ischemic heart diseases. Now, what are those other manifestations of ischemic heart disease apart from angina? That includes dyspnea, nausea, and as well as fatigue, and there can be also development of faintness. Okay, so these are the one which are nothing but the angina equivalents. And in which group of individuals these angina equivalents are more common? They are more common in elderly individuals, and they are more common in diabetic patients. So in elderly and diabetics, the angina equivalents are more common. Now, these patients with stable angina, they can go into a state of the unstable angina. Now, how can you judge that the patient has gone into a state of the unstable syndrome? So, to uncover the features of an unstable syndrome, systematic questioning of the patient with suspected ischemic heart disease is very important. Now, what are the questions that you need to ask to the patient in order to see whether the individual is developing unstable angina syndrome? That is, like, such as angina occurring with less exertion than compared to past, or angina occurring at rest, or the angina occurring upon awakening the patient from sleep. So, if for these three questions, if the answer is yes, then the patient is going into a state of unstable syndrome, right? And you have to understand that these coronary atherosclerosis, so the most common cause for ischemic heart disease is coronary atherosclerosis, and this coronary atherosclerosis, it is often accompanied by similar lesions in the other arteries. So what are the other arteries where you have this coronary atherosclerosis? That includes, there can be coronary atherosclerosis in the peripheral arteries causing peripheral arterial disease, and because of the peripheral arterial disease, there is intermittent claudication, right? There is intermittent claudication, and the atherosclerosis can also occur in the cerebral circulation causing cerebrovascular accident, that is in the form of stroke or the transient ischemic attack. Okay, so coronary atherosclerosis, it is associated with atherosclerosis in other vessels also. Now, what are the risk factors, right, for the development of atherosclerosis? So it is also important to uncover the atherosclerosis risk factors also in the individual, right? That includes, number one, the other risk factors for coronary atherosclerosis include, number one, family history of premature ischemic heart disease, that is less than 55 years in the first degree male relative, or less than 65 years in a first degree female relative. That is what is the family history of premature ischemic heart disease. That is one thing. Next, presence of diabetes mellitus, dyslipidemia, hypertension, and cigarette smoking. All these will contribute to the development of the coronary atherosclerosis, right? Now, apart from these, we have few more risk factors for causing coronary atherosclerosis. That includes the elderly age. More than 60 years is a risk factor for the development of atherosclerosis. Then male gender, because you don't have the protective hormones like estrogen in males, right? Then postmenopausal state where the estrogen is reduced, and risk factors for atherosclerosis like smoking, alcohol, and as well as the dyslipidemia. All these contributes to the development of the coronary atherosclerosis, right? And a particularly challenging problem in the evaluation is, you see, I'll tell you. So when will the pain occur? When there is a limitation of the flow, right? Now, a particularly challenging problem in the evaluation and treatment is, patient is having ischemic type of chest discomfort, but when you do a coronary angiogram, there is no flow limitation in the epicardial coronary arteries. in this group of individuals, it is challenging for the treatment because there is an ischemic type of chest pain, but there is no flow limitation obstruction. And where do you come across this particular scenario? You come across this scenario more in females rather than males. Now, why does this occur? Right? There is no flow limitation, but there is ischemic type of chest pain. Now, the potential etiologies include, number one, microvascular coronary artery disease. And how can you detect this microvascular coronary artery disease? That is being detected on the coronary reactivity testing. And this coronary reactivity testing, it is done in response to vasoactive agents. What are those vasoactive agents? Such as intracoronary adenosine. Right? Intracoronary adenosine is being used in order to test for the coronary reactivity testing. Right? Then intracoronary acetylcholine and intracoronary nitroglycerin. So these are the things, these are the substances which we use for the coronary reactivity testing. Okay. So potential etiologies include, number one, microvascular coronary disease and abnormal cardiac nociception. So these are the two things responsible for no flow limitation, but there is ischemic type of chest pain. Now, how do you treat that? If there is microvascular coronary disease, then what is that you need to do is, you need to ensure the improvement of the endothelial function. How can you ensure the improvement of endothelial function? By supplementing the nitrates, by supplementing the beta blockers, by supplementing the calcium channel blockers, by supplementing the statins, and by supplementing the AC inhibitors. So the treatment of microvascular coronary disease should focus on the following parameters. Okay. Then how will you treat if there is abnormal nociception? Abnormal cardiac nociception is more difficult to manage, and it can be reduced in some cases by it can be reduced in some cases by imipramine. Right? So this is about the clinical manifestations in patients with stable angina pectoris. Then if you see the physical examination in these individuals, the physical examination is often normal in patients with stable angina if the individual is asymptomatic. So asymptomatic stable angina pectoris, the physical examination is often normal. Right? Now, what all things you need to look in the examination in case of stable angina pectoris? You need to look for the development of atherosclerosis or markers of atherosclerosis. Now, what are the evidences telling you that there is atherosclerotic disease at other sites? The evidences that tells that there is atherosclerosis at other sites are, number one, development of abdominal aortic aneurysm, presence of carotid bruit, that tells there is carotid atherosclerosis, right? And diminished pulses in the peripheries. Okay, so that tells, right, that tells there is atherosclerosis within the peripheral arterial vessels. Okay, and you also need to look for the evidence of risk factors for atherosclerosis on examination. What are those? That includes the presence of the xanthelasma and the presence of the xanthomas. Okay, so these are the two things that will tell you about the presence of the atherosclerosis. Next thing is, in order to check if there is development of peripheral arterial disease secondary to atherosclerosis, how can you measure that? That is by ankle brachial index. Okay, so the evidence of peripheral arterial disease can be judged by ankle brachial index. So you need to measure the blood pressure of the brachial artery and check the blood pressure at the level of the ankle, and you need to check the difference. You need to compare the blood pressure between the arms and as well as the legs, and that is what is called as the ankle brachial index. And you need to know that if the ankle brachial index, if it is more than 1.30, that is suggestive of poorly compressible vessels where there is severe calcification. And if the ankle brachial index is, if it is in between 0.90 to 1.30, then it is considered to be a normal ankle brachial index. And if the ankle brachial index is in a range of 0.60 to 0.89, then there is mild arterial obstruction. And if the range is in between 0.40 to 0.59, it is considered to be moderate arterial obstruction. And if it is less than 0.40, it is considered to be severe arterial obstruction. So ankle brachial index will give you the guide of the peripheral arterial disease. And at the same time, you also need to examine the fundi. Why? The examination of the fundus, that will reveal the presence of the increased light reflex, and there will be also arteriovenous nicking. When will you have these changes in the fundi? You will have these changes in the fundi if there is presence of the hypertension. And hypertension is also one of the risk factors for the development of the ischemic heart disease. How? By causing left ventricular hypertrophy, right? Thereby myocardial oxygen demand is increased, right? And there also may be signs of anemia, thyroid disease, and nicotine stains on the fingertips from cigarette smoking. So these are also the other things that you need to examine in patients with the stable angina pectoris. And next thing is, after examination, the palpation. Palpation may reveal the cardiac enlargement. So how can you make out that the cardiac enlargement is there? That there is displacement of the LV apical impulse. There is displacement of the LV apical impulse. Okay. So palpation may reveal the cardiac enlargement and abnormal contraction of, right, abnormal contraction of the cardiac impulse. Okay. So these are the abnormality that you will see on the palpation. Next is upon the auscultation. See, auscultation can uncover the arterial bruit secondary to atherosclerosis. Auscultation, you have to look for the presence of third and as well as fourth heart sound. Why? Because the ischemia can make the individual to develop the congestive heart failure, where you will have the additional heart sounds, that is ventricular and as well as the atrial gallop. And the ischemia can also cause the papillary muscle dysfunction, where the individual will develop mitral regurgitation, and once there is mitral regurgitation, there is development of pansystolic murmur. Okay, so auscultation, what all you need to look for? The presence of any arterial bruit, presence of S3, S4, presence of the mitral regurgitation. So whenever you are auscultating, what should be the position of the individual? The position of the individual should be in the left lateral decubitus position. Okay, this should be the position of the individual upon auscultation. And next thing is, you need to rule out the other causes of angina in the absence of the coronary artery atherosclerosis. What are those? Like you take aortic stenosis, aortic regurgitation, pulmonary hypertension, hypertrophic cardiomyopathy. Even these individuals also, they develop angina, but there is absence of the coronary atherosclerosis in these patients. Okay. And what are the other things that you need to examine during the anginal attack? That includes the ischemia can cause transient LV failure with appearance of third and fourth heart sound. Just now we have discussed. Second, a dyskinetic cardiac apex. Is it seen or not? You need to palpate and check. Is there any development of MR that you can make out by development of pansystolic murmur on auscultation? And is there any development of pulmonary edema? And you will be able to make out by the examination of bilateral crepitations or rolls over the lung. So examination during the anginal attack, it includes the following, right? Next thing is, you need to test for the tenderness of the chest wall. So you see here, if there is tenderness on the chest wall, if there is localization of the discomfort with a single fingertip on the chest, right? Or if there is right? If there is reproduction of pain with palpation, right? If there is reproduction of pain with palpation, remember, all these are not the pain of the ischemia. So pain of ischemia will not increase upon palpation. Pain of ischemia will never be pointed, and pain of ischemia will never be reproduced by palpating the chest. Okay. So this will be suggestive of what? This will be suggestive of the pericarditis. Okay. So this is what is the examination of the stable angina pectoris. Now let me discuss the treatment of the stable angina pectoris. So investigations, I'll discuss it as a separate section, right? I'll discuss the investigations in ischemic heart disease as a whole in a separate section. Okay, right. Now, how do you treat these patients with the stable angina pectoris? So the treatment, it includes the following things. First and foremost, you need to identify the risk factors which are causing this stable angina pectoris. Now, what is the most common risk factor? The most common etiology is atherosclerosis. But the risk factors for the development of atherosclerosis, that will be diabetes mellitus, that will be the hypertension, that will be the chronic alcoholism, right? And that will be the dyslipidemia. So the risk factors have to be identified and they have to be treated, right? So in the treatment of stable angina pectoris, first and foremost, you should be able to explain the problem to your patient, and you also need to give reassurance about the ability to formulate a treatment plan. Okay, so first is the patient education about the disease. Second, identification and treatment of the aggravating conditions. That means what are the risk factors? Okay, then recommendation for adaptation of activity as needed. What are those adaptations that we need to take? I will discuss. Right. Then next is treatment of the risk factors that will decrease the risk of occurrence of the adverse outcome like diabetes, hypertension, dyslipidemia, alcohol should be stopped. Drug therapy for angina and consideration of revascularization. So the line of management of the stable angina pectoris is in the following manner. So first important thing is what? The explanation of the problem and reassurance about the ability to formulate the treatment plan. So a planned program of rehabilitation, what it will consist of? It consists of encouragement to lose the weight, because obesity is one of the important risk factors for the stable angina pectoris. So encourage the patient to lose the weight and to improve the exercise tolerance and control the risk factors with more confidence. So this is what a planned program of rehabilitation consists of. Right? So first and foremost, let us look for identification and treatment of the aggravating conditions. Okay, a number of conditions may increase the oxygen demand, and a number of conditions will decrease the oxygen supply to the myocardium, and thereby they will precipitate or exacerbate the angina in patients with ischemic heart disease. Okay, now what are those conditions where there is increased demand? That will be any condition whichever is causing left ventricular hypertrophy, like aortic stenosis or the hypertrophic obstructive cardiomyopathy. Okay, so they will increase the demand and thereby they will contribute to the angina. Okay, they should be excluded or they should be treated, right? Then next important is the other risk factors where there is increased demand is obesity and hypertension and as well as the hyperthyroidism. So in all these conditions also there is increased demand of the myocardium, right? And these patients, they should be treated aggressively to reduce the frequency and severity of the anginal episodes. So what should be your goal? Your goal is to reduce the frequency of anginal episodes, to reduce the severity of the anginal episodes. Okay, and so these are all the conditions where there is increased demand, right? Then, whereas decreased myocardial oxygen supply may be due to reduced oxygenation of the arterial blood. So where can you have reduced oxygenation of the arterial blood? That is a patient having the pulmonary disease or patient having the presence of the carboxyhemoglobin, right? Or the patient is a smoker. So in these individuals, there is reduced oxygenation in the arterial blood. Or this decreased myocardial oxygen supply could be due to decreased oxygen carrying capacity also. And this decreased oxygen carrying capacity, you come across this in patients with the anemia, right? So correction of these abnormalities, the one which is increasing the demand, the one which is decreasing the supply. So correction of these abnormalities, if present, may reduce or even eliminate the angina pectoris, right? They will also even eliminate the angina pectoris. Okay. Now, so that was the first thing, education and determining the risk factor. And second important thing is the adaptation of the activity. See, myocardial ischemia, it is caused by discrepancy, right? It is caused by discrepancy between the demand of the heart muscle for the oxygen and ability of the coronary circulation to meet that particular demand. That is a basic concept what we are discussing from the beginning. Now, what are the adaptations that you need, that the patient has to acquire, right? Many tasks that ordinarily evoke angina may be accompanied without symptoms simply by reducing the speed at which they are being performed, right? What are those? See, basically what you need to do, you need to do the adaptation of the activity. So the patient, what he has to do is, he must appreciate the diurnal variation in their tolerance of certain activities. That is, they should reduce their energy requirements during the morning, because during morning the metabolic demand is more. Reduce your energy requirement during morning and reducing the energy requirement immediately after the meal in patients with ischemic heart disease or in patients at risk of development of stable angina pectoris. So immediately after the meal, the individual should not go for a walk or cannot do an exertional activity, right? And he also has to reduce the energy requirement in the cold or the inclement weather. Okay, so the patient should understand that, and it may be necessary to recommend a change in the employment or change in the residence to avoid the physical stress. So if the individual is doing a particular job which is highly stressful, that you should recommend the change in the employment as well. Okay, and if you take this, physical conditioning usually improves the exercise tolerance. The physical conditioning usually improves the substantial psychological benefit. Okay, so physical conditioning usually improves the exercise tolerance of the patient with angina, and physical conditioning also, it improves the substantial psychological benefit of the individual, right? Now, how can you achieve this particular physical conditioning? A regular program of isotonic exercise, right? A regular program of the isotonic exercise that limits the individual patient's threshold for the development of angina pectoris. So the individual should be advised isotonic exercise, but that isotonic exercise should be within the threshold limit of the patient of the development of angina pectoris, or that particular exercise should not exceed 80% of the heart rate associated with the ischemia. Okay, so that sort of exercise the individual should be encouraged. And the treatment of the risk factors like a family history of premature ischemic heart disease, it's an important indicator of the increased risk of development of ischemic heart disease. So the risk factors have to be strictly treated. Hypertension, hyperlipidemia, diabetes mellitus, they have to be strictly treated in individual having the family history of the premature ischemic heart disease. Okay, and not only that, the presence of or the development of the obesity. Remember, obesity impairs or obesity reduces the treatment of the other risk factors. Okay, and this obesity, it increases the risk of the adverse coronary events, right? In addition, obesity often is accompanied by 3 other risk factors. What are those 3 other risk factors accompanying the obesity? Diabetes mellitus, then hypertension, then dyslipidemia. Okay, so this obesity often it is accompanied by 3 other risk factors which you need to take care. And the treatment of obesity and these accompanying risk factors is an important component of the management plan. So you need to see that the individual attains a normal BMI from the morbid obesity. So for that, how should be the diet in patients with ischemic heart disease? A diet low in saturated and trans unsaturated fatty acids should be supplemented. Okay, so a diet low in saturated and trans unsaturated fatty acids, with reduced caloric intake to achieve the optimal body weight are the cornerstone in the management of the ischemic heart disease. Okay, so how should be the diet? Low saturated, low trans unsaturated fatty acids, right? And reduce caloric intake to achieve the optimal body weight is a very, very important part of the treatment in ischemic heart disease, right? And it is especially important to emphasize the weight loss mainly in patients with metabolic syndrome. So patients with metabolic syndrome, what is very, very important is the individual has to emphasize on weight loss and regular exercise in patients with metabolic syndrome. Okay. Next important thing next to your obesity is cessation of the smoking. Okay. Cigarette smoking, it accelerates the coronary atherosclerosis in both the genders, in all the ages. And this cigarette smoking, it also increases the risk of thrombosis, risk of plaque instability and plaque rupture, and it will cause myocardial infarction and as well as the death of the individual. Okay, that is the reason why the individual, you have to advise to completely stop smoking, right? Then next important part of the treatment is the risk factor. And one point you have to understand and know that about the smoking is that in addition to increase in the myocardial oxygen demand, this smoking will also reduce the coronary blood flow by causing atherosclerosis. Okay, and smoking cessation studies have demonstrated important benefits with a significant decline in occurrence of the adverse events. So there will be decrease in the adverse events once you stop smoking. And even non-combustible tobacco, where will you have non-combustible tobacco? That is in electronic cigars. So even this electronic cigars, they will increase the frequency of angina episodes. Even they also have to be stopped. And another risk factors that you need to target is the hypertension. So hypertension, it will cause it will cause increase in the afterload on the heart, and it will cause left ventricular hypertrophy, and that will be a potent risk factor for the ischemic heart disease. Okay, so this particular hypertension should be thoroughly treated, and the blood pressure, systolic blood pressure should be less than 130 and diastolic blood pressure should be less than 80 millimeters of mercury, right? And if your hypertension is not treated, that will aggravate the ischemia. And next important risk factor that need to be treated is diabetes mellitus. Strict blood glucose control. Okay, so HbA1c should be less than 7%. Diabetes mellitus, what all it can cause? It accelerates the coronary and as well as the peripheral atherosclerosis, and it is frequently associated with dyslipidemia, that is hypertriglyceridemia, most common, and it will also cause increase in LDL. It will also cause increase in VLDL, and it will also cause increase in the cholesterol as well, right? And thereby it increases the risk of angina. It increases the risk of the myocardial infarction. It increases the risk of sudden cardiac death. So that is what the diabetes mellitus does. Okay, so that is the reason why controlling the dyslipidemia is very, very important. How much should be your target LDL? Target LDL should be less than 70 milligrams per deciliter, and target triglycerides should be less than 150 milligrams per deciliter. Okay, and target HbA1c should be less than 7. So treating the risk factors is also a very, very important stage of the treatment. Okay, and next important is how will you control that particular, and okay, you also need to know how to treat this dyslipidemia. What are the various groups of drugs for treating this dyslipidemia? I will tell you now.